My name is Erin Himawan. I am a research fellow at ILC, and I will be chairing today's session. Very grateful to be here. I'm stepping in for Professor Blaine today, who has had to pull out due to unforeseen circumstances. And thank you all for joining us today. We are really delighted to have you all with us, and we're joined by a really excellent panel of speakers. Over the course of this year, ILC has been speaking to charities, medical experts, and people with underlying health conditions to understand the barriers and opportunities associated with routine immunization in clinical risk groups. Patrick Swain, a Research and Projects Officer at ILC, will be presenting a report which collates these views and makes recommendations on what the public sector, medical organizations, and in particular charities should do to improve routine vaccination uptake rates in clinical risk groups. Our panel will also respond to the report's findings and recommendations and share their thoughts on how we can improve routine vaccination uptake among people who are at risk in the UK. We will then want to hear from the audience, hear your views in the Q&A session. Before we get started, there are, however, a few housekeeping rules I'd like to quickly run through. First is internet issues may affect sound and video, so if this does occur, please do bear with us. We'll try to get back on track as soon as we can. At the bottom of your screen, you will see a chat function to communicate with panelists and delegates, as well as a Q&A feature where we will be collecting questions for the panelists. So please do use the Q&A feature, submit your questions throughout the session. In the interest of time, we would, however, appreciate that if you could keep your questions short and focus on the topic of today's webinar. If you are having any issues with audio or video throughout the webinar, try to connect with using an Ethernet cable or through hotspot using your phone. If you do get disconnected from the webinar, do use the same link from the email confirmation we've sent out to join back in. If you are all invited to post comments on Twitter using the Reducing the Risk hashtag and at ILC UK. The webinar will be recorded and published for public access on our website and YouTube channel, presentation slides, and the recording will be published the next day. All right, so without further ado, I would like to move on to the presentation of the report by Patrick. Patrick joined ILC in August 2020 as a Research and Projects Officer. His role involves producing research and policy ideas for ILC with a particular focus on vaccines and immunization. Patrick has a BA Honours degree from the University of Surrey in politics with creative writing. He previously worked with the public affairs team at Airbus UK, as well as the research team of another think tank based in London, the Centre for Entrepreneurs. Patrick, the floor is yours.
Thank you very much, Erin. It's a pleasure to be here today. And thank you to everyone who is joining us. Just before we get started, just for anyone who is new to ILC, we're just going to give a bit of a background to who we are and what we do. So the International Longevity Centre UK, or ILC, is the UK's specialist think tank on the impact of longevity on society. We're focused on making society work for everyone, regardless of their age. And we are one of the founding members of the ILC Global Alliance, which is a network across 16 countries who are all focused on longevity. So in my presentation today, I'm going to start talking about the context that led to this project and looking at some of the data on routine vaccination in at-risk groups. And then I'm going to talk about some of the content of the report, namely the barriers to routine vaccination in clinical risk groups and our recommendations on improving uptake. So our research primarily looks at 8 at-risk groups, and those are asthma, chronic heart disease, chronic kidney disease, chronic obstructive pulmonary disease, also known as COPD, diabetes, HIV, leukemia, and myeloma. And we started out this project by reviewing the literature and looking at the data on vaccine uptake to get a bit of a background understanding of the attitudes and current levels. And then we went on to have interviews with 8 people from these risk groups, so 1 from each group. And we also had conversations with about 20 health-focused organizations, gathering their perspectives on this topic. So what does routine vaccination uptake look like in at-risk groups? Well, if we start by looking at the current COVID-19 vaccine data, we could say it's very positive. The NHS England data on the screen at the moment currently is divided into 3 categories: at-risk or carers under 65, the clinically extremely vulnerable, and the UK population average for those over the age of 16. And what we can see here is that despite at-risk groups, the data here suggesting that it's only about 4 in 5 people, and it's lower than the UK population average, that is still pretty high. And clinically extremely vulnerable, or those who have been told to shield by the government during the pandemic, is actually 3% higher than the national average. So what this indicates to me is that there's a strong awareness and willingness from this group to get vaccinated. But despite this, when we look at other routine vaccination, we could say that it's actually quite low. Amongst clinical risk groups for flu and pneumococcal vaccine data, it is quite low, and it's around the 50% mark, possibly with the exception of diabetes, which does reach 60% for flu vaccine. Everyone else is around or below 50% for flu, and then the average is 17% uptake for pneumococcal. But has COVID-19 shifted attitudes on vaccine uptake in at-risk groups? When we look at the 3 past flu seasons, we could suggest that there has been a positive impact with a spike in recent years. So there's been about a 9% increase from 2019-20 to 2021. But unfortunately, despite these increases, we are still far off the WHO Europe target of 75%. And whilst this target was reached last year for over 65s, the same cannot be said for clinical risk groups. Possibly with the exception of Northern Ireland, who reached around a 68% uptake last year, everyone else is still around the 50% mark across England, Scotland and Wales, and it's far below the target of 75%. And as such, there's still a long way to go with improving vaccine uptake in clinical risk groups. And understanding these barriers behind low uptake is going to be crucial in order to change this. So given this, what are those barriers and what are the key challenges facing at-risk groups when it comes to routine vaccination? Well, our research found that there are 4 key barriers associated with low uptake in at-risk groups, and these can be broken down into communication barriers, structural barriers, personal factors, and accessibility issues. The first of those is communication barriers, which can then be broken down again into another 3 categories, including vaccine misinformation, inaccessible information and poor communication, and inconsistent messaging from some healthcare providers. And now I'm going to show some quotes from the conversations that we had with at-risk groups and charities. And the first lot is on misinformation. So charities and at-risk groups acknowledge that vaccine misinformation exists and could harm uptake. Misconceptions about vaccines can cause some at-risk groups and communities to become more hesitant taking vaccines. For charities, they express that the concerns with misinformation was because it's being shared through channels which are hard to monitor. As we can see here from Kidney Care UK, they say that it's often being shared on places such as WhatsApp, which does have a direct impact and causes refusal in some places. And for some of our at-risk people we spoke to as well, they also speculated that misinformation could have a negative impact on uptake, especially since the COVID-19 pandemic, with conspiracy theories against the government vaccination program, and that potentially people's most negative views about vaccination are more likely to be rooted in this misinformation. Secondly, we came across inaccessible information. What do we mean by that? Well, what we mean is basically charities have acknowledged that while they're there to provide information, it's not always landing and it's not always there accessible to some at-risk groups. This was actually mentioned by people such as Blood Cancer UK, Leukemia UK, who suggested that whilst they are providing information, it's not necessarily accessible, especially to marginalized and underserved communities who are not always reached out to, represented in the comms, or made aware about the information that is available to them. And as such, some charities accepted that not everyone is fully informed about vaccination. And finally, on communication barriers, we also came across issues with inconsistent messaging. While it was not the case for all at-risk groups, we found that some people, certainly some blood cancer patients who had undergone stem cell transplants, had faced these sorts of barriers. And we found that some medical professionals were more hesitant to administer vaccines given the compromised nature of these people's immune systems. And one person with multiple myeloma mentioned this in their interview with us. They suggested that it was a bit confusing when they went to schedule their revaccination program. And the person they spoke to on the phone, the nurse, assumed that they were looking for a child, which goes to show that there's not a lot of information potentially out there for some healthcare professionals and a lack of understanding, which creates a barrier between the patient and the person trying to access vaccination. Secondly, we came across structural barriers with routine vaccination in at-risk groups, and this especially is the case amongst ethnic minority groups and people living with HIV. People from ethnic minorities are more likely to be distrusting of organisations who advise on or administer vaccination due to historical structural racism, a lack of transparency, and fears of discrimination. And similarly, people living with HIV face stigmatisation, and they may not choose to disclose their status to their GP, which can lead to a lack of access. So just a bit of background on uptake in ethnic minority groups. On screen here is just a comparison between 3 of the lowest ethnic minority groups versus white British at-risk uptake. And what you can see here is there's well over a 25% difference in uptake levels between Black Caribbean, Black African, Pakistani, and white British at-risk groups. And often this low uptake is associated with the lack of trust and misgivings in the institutions who administer and advise on vaccines due to these historical structural racist barriers. And we can see that on the screen here. So we spoke to one organisation who suggested that the mistrust element of vaccine hesitancy is huge, partly because no one's made any attempt to misunderstand where those sentiments come from. And we also spoke to people like Diabetes UK, who acknowledged that there's a lot of anxiety around not having enough diversity in the clinical trials, because the majority of research is often done on white, less diverse backgrounds, and that can feed into the vaccine skepticism. Stigma and discrimination also affects other groups, such as those living with HIV, who may be less likely to take vaccines because of this. Around 1 in 5 people living with HIV do not disclose their status to their GP because of these fears. And the HIV charities we spoke to expressed these concerns, especially in relation to the COVID-19 vaccine, and many people with the condition missing out on getting that vaccination because they had not stated their status. And this is the kind of the quotes we get from people like Terence Higgins Trust and National AIDS Trust, who do make mention of that stigma and discrimination barrier. We also came across personal factors as a potential barrier to uptake in clinical risk groups, namely needle phobias, time constraints and medical pressures, conflicts with personal beliefs, age, and a loss of body confidence. So one of the more common personal barriers to vaccination is the fear of needles. And whilst the at-risk groups that we spoke to did not suggest that this was an issue for them, they speculated that other at-risk people might not want to get vaccinated and feel discouraged by it because of these phobias. And whilst this barrier is not unique necessarily to at-risk groups, it is certainly one that could prevent somebody from getting vaccinated. Secondly, not having enough time to book or attend a vaccine appointment was seen as a potential barrier. As you can see on the screen here, we have a quote from somebody with asthma who suggested that if they've ever been guilty of not having their flu jab straight away, it's because something else has got in the way. And someone with leukemia suggested that some people are just too busy with their lives and they just don't get around to getting vaccinated. Time constraints were more often associated, however, with medical pressures. And this was especially the case for at-risk individuals with weakened immune systems. Often added medical pressures can sometimes be too much for people, meaning that routine vaccination isn't always prioritized. And this was certainly the case with somebody who had myeloma, who suggested that they were just very, very exhausted after their stem cell transplant. And Anthony Nolan also acknowledged this, that the medical pressure of trying to stay alive and keep up with other medication going through cancer treatment means that immunization is not prioritized. And National AIDS Trust also referenced this too in their conversations with us. Conflicts with personal beliefs was also seen as a potential barrier. So some people's lifestyle choices or faith beliefs could be contradictory when it comes to the contents of some vaccines. Whilst this was more anecdotal, some of our conversations did highlight this, and suggestions were made that, you know, for religious beliefs, some people might not want to get vaccinated, and there may be restrictions in this area. An interesting one was age as well. Some people believe that, you know, younger people are less likely to get vaccinated than older people, under the old cliche that you're young and you're healthy, or healthier than when you get older with an underlying condition, and you might be able to, you know, fend off anything. And this is what somebody with diabetes suggested to us. They suggested that they thought when you're in your late teens or early 20s and 30s, you probably say you don't need that vaccine because your condition, for them, diabetes, was under control. and it just wasn't as relevant. But when you get older, you need a form of safety net. And in order to do that, you would get vaccinated. And in fact, when you look at the data as well, uptake is actually 13% higher in at-risk individuals aged 50 to 64 than it is for the overall cohort of 16 to 64. So that's quite interesting. And finally, one person with leukemia suggested that they had a loss in body confidence, and this acted as a barrier for them. And they cited that because of their because they weren't healthy anymore because of their condition, that they thought that having a vaccine wouldn't really make much of a difference. And as you can see on screen here, they say, when you're unsure and unclear about what's happening internally to yourself, why would you add something else alien into that mix? Nonetheless, when speaking to this person, interestingly, they did get the COVID-19 vaccine, again, which I think highlights how people's attitudes have fundamentally changed during the pandemic. And finally, accessibility issues were seen as a potential barrier. These were broken down into mobility issues to do with physical barriers. Some charities also cited appointment inflexibilities. And also a couple of people suggested that supply issues with vaccines had prevented them from being able to get vaccines easily. So our findings suggested that accessibility issues sometimes stem from potential mobility barriers. So this was the case for the person with myeloma, who suggested that, especially with the COVID-19 vaccine, they were worried that they wouldn't be able to get it because they can't stand for very long. And if they were having to queue up, as initially with the beginning of the vaccine rollout, when people were queuing in the mass vaccination centres, this might have posed a problem for them. Fortunately, they were able to rearrange their appointment at, I think, their local GP surgery, which was closer to home. But obviously, this is not the case for everyone, so this could be a potential barrier for a lot of people. Appointment inflexibilities could prevent people from getting vaccinated too, or even just put them off in the first place if they think it's too difficult to arrange or schedule their flu vaccine or any other routine immunisation. And this was raised by Asthma UK and the British Lung Foundation, who said it probably comes down to accessibility issues about being able to get an appointment at a time that works for you. And there's not always a lot of flexibility in it. Finally, some at-risk groups mentioned how a lack of supplies caused them to be unable to achieve or to get routine vaccination. With an increase in the number of people getting the flu jab since COVID-19, as I showed on the previous graphs, supply chain issues could become more common, and we are seeing this more in the news at the moment. Therefore, ensuring demand is met for at-risk groups is going to be crucial. And again, you can see with some of our conversations here that someone with asthma have said, I always attempt to get one, and I say attempt because they're hard to get. I have to wait until the doctors have a sufficient supply. So given these barriers, what are the opportunities to help increase uptake? In particular, what can charities do to encourage and sustain uptake? And why charities? Well, our research found that at-risk people regard them as trustworthy and reliable. Given their independence and specialist knowledge of health issues, at-risk people suggested that charities were more approachable. They can offer tailored advice to people, and we see charities therefore as the key change makers who are best suited to encourage at-risk people to seek routine vaccination. We identified 3 potential opportunities to improve routine vaccination in at-risk groups, and these included 1, improved vaccination communications and information. Specifically, including more tailored messaging to suit specific at-risk groups, encouraging peer-to-peer communication between people with the same conditions, and more signposting between charities and public health bodies. 2, closer community collaborations and partnerships by working with faith leaders and local community leaders to disseminate information, and more cross-sector partnerships between the third and public sectors, such as using joint social media campaigns. And 3, finally, improving vaccine access, which could be achieved through innovative solutions, such as fostering collaborations between ride-hailing apps or lift services to get people from A to B, and also as well, just improve signposting to let at-risk groups know where they can get their vaccines. And all of these recommendations have helped form part of our good practice guides designed to equip charities with the tools to encourage and promote and sustain routine uptake of vaccinations, routine vaccination uptake, in at-risk groups. And this can be downloaded for free from our website. We hope that charities can use it as an effective tool heading into the flu vaccine season. So that brings a close to my presentation, but I do welcome any additional thoughts and ideas. So if you would love to discuss these with me, then please don't hesitate to email me using the link on the screen. And thank you very much.
Great, thank you so much, Patrick. Really interesting presentation, really lots to pick out from there, and I'm sure our panelists will respond to some of the findings from your report. So now we'll be moving on to our panel presentations, and I'd first like to invite Andrew Lane, who is the chair of the National Pharmacy Association and represents Buckinghamshire, Oxfordshire, Berkshire, Northamptonshire. He lives in Oxfordshire and was elected to the NPA Board of Management in April 2010 to represent the Southwest. Andrew, the floor is yours.
Thank you, Aaron. Yeah, I suppose when we started the pandemic, seems an awful long time ago now, doesn't it? And we learned about mass vaccination centres. There's a lot of stuff in the news about where you could go, where you couldn't go. A lot of supply issues. Patrick's just talked about whether or not the Pfizer vaccine would come on in time. The AstraZeneca one then followed through. I think it was just very confusing for lots of people. And, you know, we've sort of seen that progression, haven't we? Where many GP sites were closing because of the pandemic. The pharmacies stayed open. We campaigned every week to make sure the ministers, government, the NHS recognised that community pharmacy is a place where a lot of the population already go to get their flu jab, for example. So we're absolutely perfectly positioned to get involved in the COVID vaccination programme, which eventually we managed to get the government to recognise that pharmacy could get involved. Obviously, initially, I think, if you remember, the Pfizer vaccine was limited to those that could do 1,000 a day. And that's way beyond the means of many small local pharmacies. So we persisted, and eventually, they started to allow the breakup of the Pfizer vaccine down to sort of 400, which was more manageable for the smaller community pharmacies. And eventually now we're seeing small community pharmacy sites achieving 100 vaccines a week. And I think if you look at some of the statistics since the pandemic started, and bearing in mind there are 11,500 community pharmacies in England, and we've got, I suppose, really interesting stats coming out of the research that the NPA did. So we're going to focus the remarks on some of those UK's prior preparedness for the pandemic. It's the most visited of all settings in which the NHS services are provided, and 68% of the population had visited a pharmacy since March 2020, since the first national lockdown came into effect. The number of pharmacies that were potentially closing due to chronic underfunding and rising costs has been accelerating. So we're in a backdrop of potentially a number of community pharmacies having to close because they struggle to keep the doors open just through financial pressures. At least the same number of community pharmacies as we currently have in the network, and ideally a community pharmacy is there in every neighbourhood. So we've had some consistency throughout the pandemic. We've also had some IT issues. Certainly there were, when patients were being directed, if you like, to vaccination centres, we had some problems with logging on. So I think there were, log-on issues for people. They'd get directed to a particular part of the system, whether it be a mass vaccination centre or a community pharmacy. And some of the IT wasn't working early on. And I think a lot of people got directed to mass vaccination centres where they could have actually had a convenient vaccine in their own neighbourhood. And this is perhaps why, we saw some of the early lack of uptake, because people recognised they could actually wait for their pharmacies coming online because they lived round the corner from the pharmacy, and they wouldn't have to necessarily travel. I mean, where I live in Oxford, for example, we have the Kassam football stadium as a mass vaccination centre. And therefore, if you live on one side of Oxford, it can take an hour to get around the ring road to get your vaccine. And if you're in an at-risk group, for example, you don't necessarily want to risk going to what could be a mass vaccination centre, standing up in a queue, and therefore your pharmacy is really convenient. And you perhaps, for your medication that you're on, you trust the pharmacist that you know, you're more than happy to wait for the vaccine at your local pharmacy. So I think we've seen, a shift in people's patterns. They've got used to pharmacies vaccinating. We're getting ready. Many of our members are getting ready for the booster program, of course. That will be on us imminently, and we sort of welcome, I think, the opportunity to be involved in that program. They're well placed for delivering booster COVID vaccinations, allowing GPs really to focus on clearing the backlog that obviously we've been hearing significantly is in the NHS. Pharmacies have been central to many NHS responses to COVID throughout, as I mentioned earlier. And it's just one of the many ways that community pharmacies stepped up. I actually met Nadeem Zahawi, the vaccine minister, and he was actually conscious that people have a high level of trust in their local pharmacies. We talked about vaccine hesitancy, and he recognised that they're present in all communities, including the most deprived areas of the country. And you often find your local pharmacy will often, in the local neighbourhood, speak the language of the ethnic diversity of that population. For example, I used to have a pharmacy in Slough, and my pharmacist spoke 7 Asian languages. So when you see the stats that Patrick put up, for example, particularly I think the one with the large Afro-Caribbean, or big sort of reduction in the take-up, particularly of people at risk, a lot of those Afro-Caribbean communities will have pharmacies perhaps with people who are ethnically of the same population. And I think that there's that trust level. So I think we've been quite fortunate that where pharmacies have stepped up to want to offer the vaccine, then the local communities have benefited massively from that service. I don't know, is there another slide there, Aaron?
Sorry, Andrew?
Is there another slide on the deck, or is it just?
I don't believe so. I think it's the next person. Patrick, would you mind changing it to the next slide?
I'm not too sure if they've put my slide deck up, so forgive me, Patrick, if it's not got to you. But I'm happy to speak because I've got a prepared sort of. I
do apologise, Andrew. I don't believe I got those, but
okay, no, that's all right. That's absolutely fine. So I'll sort of continue. So at the start of June 2021, pharmacy-led sites had vaccinated over 5 million people against coronavirus. And at that point, approximately 600 pharmacies had been engaged in the process. And the number at September 21 now is assumed to be between 1,000 and 2,000 pharmacies. I can't get the exact number from NHS England, but it's going to be in that sort of order. So unlike in the first phase of the vaccine programme, where pharmacies had to be able to do, as I said earlier, the Pfizer vaccine, 1,000 vaccines a week, some pharmacies can now participate by administering as few as 100 vaccines. And that's obviously opened up the possibility of many more taking part in the programme. I think a YouGov survey showed that 9 in 10 people would consider getting a COVID-19 booster vaccine at a pharmacy. And that survey was carried out between the 1st and 2nd of July. It showed that 90% of people who intend to get a booster jab might actually opt for a pharmacy site if locally available. 67% said this would be very convenient, compared to 30% for mass vaccination centres. I suppose that was the example I described earlier. And overall, 82% of people said they would be interested in getting a booster jab with less than 10% definitely not interested. So obviously the NPA, my association, we welcome the second wave of pharmacist-led COVID vaccination sites. 65 are going online in the coming days in pharmacies and pharmacist-led sites across England. And we welcome today the expansion of that vaccine programme, and again claim that thousands of pharmacies could eventually be involved and accelerate that rollout. So it represents a significant expansion of COVID vaccination sites, but pharmacies can ultimately go a lot further to protect the population. England's network of 11,500 community pharmacies is a formidable asset in the collective response to the pandemic, and they're collectively capable of protecting millions of people if given the chance. I believe that pharmacists are going to be the sprinters and the marathon runners in the race to vaccinate the whole adult population by the autumn, and then keep us protected year after year, as we've done with flu. And I think, if you just look at some analogies around the flu statistics, there've been at least 2.6 million vaccines administered by Community Pharmacy England during the 2021 flu vaccination programme. So just some comparisons there for against the flu. So that's probably closer to 3 million if we look at all the data which when it comes through, but it was the largest flu campaign in the country's history, as you probably remember Nadeem Zahawi at the time commenting on that. So I'm happy to take questions. I don't know how you want to run this next step, Patrick. Happy to take questions individually or wait till all the panelists have provided theirs. But, I've thrown a few statistics at you there. Community pharmacy, accessible, right in the middle of all the populations where clearly there are people who are vulnerable and probably go to their local pharmacies for their medication. So I'd like to see more pharmacies coming online, and they can have those conversations with those people who are hesitant about the vaccine and probably dispel some of the myths, as your surveys found out that there's an awful lot of hesitancy out there potentially that we weren't aware of. There are other issues structurally, for example. Just an example. Yesterday, my electrician was in, and I asked him, "Oh, have you been vaccinated?" And he said no. He said, "I can't get to see my GP. I don't want the AstraZeneca vaccine. I have to have the Pfizer vaccine because he's got a condition that means he has to have that. But he hasn't had his first jab yet, and he's 45. So I wonder how many more people are out there like that maybe are just not being directed to an alternative if they're struggling to get it from their GP. He wasn't aware, for example, that he could actually go and get it from his pharmacy and book in on the national booking line. So again, I think there's a lot of knowledge that pharmacies can inject in their local communities, for want of a better word. I think, as more and more of us come online on, particularly for the boosters, we need the NHS to promote that as much as they are promoting the GPs at the moment, so people have a choice of where they go for their vaccine. So yeah, happy to take questions.
Thank you, Andrew. We will run through all the panelists' presentations before we go open up the floor to Q&A, and then we can the audience can ask you some questions at that time as well. But thank you for that presentation, and I think really underscores the vital role that community pharmacies play in vaccination. And I think the hope is that their role, which has clearly been maximized during the pandemic, is expanded as we move forward with routine vaccination as well, and for those at risk. So moving on to our next speaker, Christina Marriott, CEO of the Royal Society for Public Health. Christina has been the Chief Executive of RSPH since May 2020, previously the Chief Executive of Revolving Doors Agency. She has experience in both national and regional roles in the NHS, having led a place-based health equity program before becoming National Lead for Health Inequalities in the then newly formed NHS England. Christina, great to have you. Over to you.
Thanks, Alan. I feel like I should slightly defend max vaccination centres at this point. I had a fantastic experience. I never had to queue for more than 30 seconds, and there was just an amazing army of volunteers and the expanded workforce that I will come on to next. And I think that for me, picking up on some of the comments that are already coming in, that for me is really important about how we take the innovation of the COVID vaccinations to actually do better. Because as Patrick was showing, we're not doing that well on our routine vaccinations, and we particularly don't do that well for some communities. So much as absolutely there's a role for local pharmacists there, this is the opportunity for us to go beyond what we have achieved so far as a system. So when we think about the COVID-19 vaccination rollout, it has been truly distinctive from the UK's routine immunisation programmes, not just in terms of its scale, but also in terms of its infrastructure, not least its data infrastructure, and the resource behind its delivery. In the last 18 months, we have seen the most amazing agility. Speaking as somebody who used to work in the NHS has never shown so much agility. And we've really seen collaborative ways of working across public health systems. We have set up the team of teams to deliver this vaccine rollout. And the success in the development and the rollout of the vaccinations has played a key part in demonstrating and promoting the value of vaccinations amongst both policymakers and the public. And it's facilitated a new form of public engagement. The public has been engaged as trial participants, as volunteers in clinics, as champions of the vaccination. The question now is how much of that innovation will be maintained in the years to come for the routine vaccination programmes. There is a real risk that the system will default to its old ways of working. And if we don't act together now, partnerships are going to break down, community engagement's going to end, and resources will dry up. So as per my brief, I'm going to focus specifically on the innovation championed and delivered either with or by third sector organisations. We've already had some questions about inequity in vaccine, and we know that amongst various demographic groups, there have been long-standing issues facing all the immunisation programmes in the UK. The data has not been consistently collected to establish how great these disparities are and along which social demographic lines they typically occur, and therefore we've not been able to monitor them or target action at them. At the tail end of last year, the Royal Society for Public Health was raising this issue, and particularly around disparities in vaccine hesitancy across different ethnic groups. And from mid-January 2021, 7 weeks after the vaccine rollout started, ethnicity started to be recorded as part of the vaccination collection to monitor and address the differences in uptake across different ethnic groups. There was a new Vaccination Equalities Committee led by NHS England and Improvement. It was established to bring together government departments, directors of public health, local authorities, and third sector organisations to address inequalities. And these third sector organisations, together with DHSC, Public Health England, and HSE&I, were instrumental in developing some targeted communications for different demographic groups, ensuring the resources were available in a variety of languages and formats, including Braille and those accessible for those with hearing impairments. So, for example, Rethink developed communications to address the concerns of people living with severe mental illness, which was then followed up with guidance for vaccinators to support people with learning disabilities or people with autism. Additionally, in October last year, the Ministry for Housing, Communities and Local Government made £23 million available for community champion schemes run by 60 councils and their voluntary groups across England to encourage the vaccination take-up. Then in March 2021, they made a further £7 million available to reduce inequalities. We would argue that it is now vital that these resources are made available for all the routine vaccination programmes, because we know the inequalities also sit in those routine vaccination programmes, and that people with mental ill health, learning disabilities and autism continue to be seen as priority groups for adult vaccination programmes. It's also vital that the funding is maintained for those community champions. I'm sure many of us will have seen Public Health England's recent evaluation of the impact that showed really incredible results, and it's crucial that the funding for such schemes is maintained beyond the pandemic. We know from our reports, Moving the Needle and Mind the Gap, that access is one of the main barriers to routine vaccination uptake among adults. We know, for example, this has got particular impact on working age adults, and particularly in London. They just can't get even to their pharmacy, let alone to their GP. During COVID-19, to improve access, clinics have been run in various new settings using an expanded workforce, often working extended hours. Vaccinations have been administered on Saturdays and Sundays in the evening in GPs, as well as mass vaccination centres, community pharmacies, mobiles, pop-up clinics, places of worship, hostels. They have been everywhere and they have been open at all time. And partly that was enabled through a data infrastructure that I'll come back to, and partly it was enabled because the statutory instrument to amend the Human Medicines regulations enabled unregistered staff with appropriate training to administer the vaccine. As a result, the vaccine workforce expanded to allied health professionals, including St John's ambulance volunteers. This vast expansion of the vaccination workforce was enabled by a national recruitment campaign with 10,000 new unregistered vaccinators. That's an amazing workforce to bring on stream that quickly. Going forward, we really need to think about how can we maintain this improved access and this expanded workforce for routine vaccinations so that access is no longer a barrier for adults. We need to move quickly to capitalise on both the expanded workforce and on the integrated data system that enabled this truly amazing vaccination programme. The success of the COVID-19 vaccination programme depended on having boots on the ground, listening to the concerns and the questions in different communities and developing tailored approaches. The importance of trusted local messengers and building confidence in the vaccine cannot be overstated. In fact, we know only too well that tokenistic attempts at community engagement do not and did not work. They did not drive up uptake. But empowering communities to share the messages themselves is the most effective way of increasing uptake. And the voluntary sector is often the advisor, the enabler. We produce a wealth of resources. We translate public health guidance and information to a wide range of groups and into a wide range of contexts. It is so important that we continue to seek opportunities to give communities back the power to lead on health promotion, prevention and protection programmes, including immunisation. Many of the innovations seen during COVID-19 vaccination programmes were ones for which the third sector has long advocated, including ourselves. While no one would wish for a mass vaccination programme to be necessary, it had at least testified to the soundness of the recommendations which have been made with regards to routine vaccinations, including Patrick's report being launched today. But the fact that these suggestions have been implemented for COVID-19 does not mean that the need for advocacy has disappeared. Indeed, it is clear that the possibility of defaulting back to business as usual feels very real to partners across the system. We are in danger of losing the gains we have made. We can all imagine how local investment and community engagement initiatives will dry up once the rollout is complete, that efforts to reach the underserved could fade, and that organisational barriers could again become impermeable. Indeed, the Royal Society for Public Health has heard recently in a series of roundtables with people from across public health and the NHS and the voluntary sector that many of the COVID innovations could slip away if we do not support them. The time is now to embed these innovations, including the team of teams approach to vaccination that brings the NHS, volunteers, public health, community champions, and the voluntary sector into one effective workforce. Given the significant inequalities in routine immunisation uptake, we must not miss the opportunity to embed these hard-won lessons from the COVID-19 vaccination programme more widely. And one of those opportunities is the opportunity to work with the voluntary sector to ensure that routine immunisations reach everyone. Not only would this strengthen the country's protection against infectious diseases for which we already have vaccinations, but it would ensure that we have the infrastructure we need should another pandemic hit. And with the idea of another pandemic, I think I should hand over back to Aaron.
Thank you, Christina. Really interesting, and I'm sure we'll come back to these key themes that you've addressed in your presentation. But I think it's really one of the biggest or one of the clearest sort of wins in terms of COVID pandemic was these newly forged partnerships that you describe. And I think, as you mentioned, it's absolutely crucial that we maximize on these and we are able to continue to have these partnerships so that people, regardless of age, regardless of where they live, can continue to access of routine vaccination in a way that benefits everyone. So thank you again. Moving on to our next speaker, David Green, nurse consultant for immunizations and Public Health England. Following a varied nursing career, including general medicine, cardiothoracic ICU, and infection prevention, David became an immunization coordinator in Calderdale in 2008. He has been a nurse consultant for immunizations with the National Immunization Team at PHE in 2014. David completed an MPH at the University of Leeds in 2014 with a dissertation on the efficacy and safety of pneumococcal vaccines in the elderly. David, the floor is yours.
Hi there. Thank you for that introduction. Can I just check that you can hopefully both see and hear me?
Yes, I can. I hear you, and I believe we can see you as well.
Okay, thank you.
I was just trying to find you at the top. We're fine.
Very much. Cheers. Okay. So I'm going to talk about why there are disparities in vaccinations for clinically at-risk groups and what some of those factors might be. Talk a little bit about the COVID vaccination and lessons learned, and then talk finally about what public health organisations can do to increase and sustain uptake in clinical risk groups and how they might be able to work with charities to achieve that. So I think it's important that we don't assume that the factors that can affect uptake are the same for each group or indeed each individual. Some individuals may not actually know that they're in a high-risk group, or they may be attending a healthcare facility that does not routinely offer vaccination. So I think one of the things that's important is to make sure that the people who are looking after individuals in at-risk groups are aware of the need for vaccination, and ideally offer vaccination at the same time, if possible. I also think that some of these patients or some of these individuals have got complex medical needs. I mean, we call them high-risk groups or long-term conditions, for example, but they do have complex medical needs, and I think it's important that we try and make the service fit the individual. If we look at pneumococcal vaccination as an example, and this was included in the ILC's report, we do see quite big disparities between different eligible groups. So the group with the highest uptake of that vaccine were those who've had a cochlear implant, and they had 76% uptake. The group with the lowest uptake was those with chronic liver disease on just 26% uptake. I'm going to speculate slightly here, but it's quite possible that the ENT surgeon who's planning the cochlear implantation will likely recommend to the patient that they have a pneumococcal vaccine. With chronic liver disease, I think that encompasses a range of different conditions, such as hepatitis and chronic cirrhosis. I think it's maybe a perception thing. Perhaps people don't actually necessarily equate their condition with eligibility for things like flu and pneumococcal vaccines under this kind of blanket term of chronic liver disease. In terms of COVID vaccination rates, they have been remarkably high. I think it's been a fantastic rollout, and what lessons we can learn from that. I think my first reflection on the COVID pandemic vaccination program is that it has been a remarkable success, and I think great credit should go to everyone involved. But I think we should exercise some caution in comparing this program with other programs that target those specific conditions for which particular vaccines are recommended. The COVID vaccination program is effectively a universal program, which now extends down to the age of 12 years. Whilst there's been prioritization in that program based on factors such as age and people's underlying health conditions, in a program that goes down all the way to 12 years, this will inevitably end up inviting more individuals to vaccination, including those with at-risk conditions. And I also think that COVID as a threat to our health has been very immediately identifiable to the public. It's been a very high profile news item for over 18 months now. People in general may not think about routine vaccinations in the same way because the diseases that those vaccines protect against are now quite rarely seen. And I think that may have had an effect on the public's perception of the risks and benefits of vaccinations. I think the health system needs to work together to improve vaccine uptake, and I think that includes bodies such as mine, which is PHE, or the UK Health Security Agency, as it will become shortly, and also general practices, community pharmacies, integrated care systems, primary care, secondary care, and those that commission the immunisation programmes in NHS England, their public health commissioning teams. And I think together we need to utilise the available evidence on what works to improve uptake. Personal invitations and letters, phone calls, for example, from the care provider. We know from research that's been done into influenza uptake in general practice, we know that those sorts of strategies can result in higher uptake. There are other interventions as well, such as having a named person in charge of vaccination programs in that care provider that are also evidenced as being actions that can improve uptake. So I think there's also scope for working more closely with charities on improving communications to specific groups of individuals, particularly around sort of flu and pneumococcal vaccines. As the ILC report has highlighted, it is important that that in communications, people are able to recognize themselves in those messages. And I think we could probably work more closely with charities to achieve this. So in conclusion, it's going to be very important to have a good relationship with charities, and I welcome the opportunity to build and strengthen on those links that we have with those charities and the ILC. Thank you.
Brilliant. Thank you so much, David, for that presentation. Moving on to our next speaker, Doug Brown, who's the Chief Executive for the British Society for Immunology. He leads its mission to support and transform immunology research to the benefit of human and animal health. Doug comes from an immunology background, having completed a PhD at the University of Cambridge in HIV research, followed by a postdoctoral position at NIMR Mill Hill, now the Francis Crick Institute on Malaria and Stem Cells. Doug, over to you.
Brilliant. Thank you very much, Aaron. Hopefully you can hear me. I've seen the nod. I think you can. Excellent. And I've got some slides to talk to as well. So just a couple you'll be pleased to hear. And as you can probably tell from my biography, we're coming at this from a slightly different perspective, but actually a lot of what's been said we're in full agreement with, and we'll touch on that during my presentation. So in a nutshell, British Society for Immunology, if you haven't heard of us, you can be forgiven. We are a charity, but we're also a professional society representing over 4,000 people working in immunology for a number of years now. So even pre-pandemic, we've been interested very much in vaccination, focusing previously a lot on childhood vaccination, but a big role during the pandemic, of course. So in the next few minutes and over the next few slides, really going to give our perspective on the value of vaccines, but also on the lessons that we can learn and take into, hopefully, routine vaccination, or the lessons we've learned from the pandemic that we can take into routine vaccination. And Patrick, thank you very much for clicking through the slides. If we can go on to the next one, please. So, I mean, first of all, I just wanted to congratulate the ILC on such an excellent report. It was a really great read and highlighting all of the important areas. So wonderful to have another strong piece of thought leadership out there, raising awareness of the key issues in vaccination. So thank you to you guys at the ILC for getting this one through. And as you've seen in the report and said by others on the call here, even though vaccination is clearly seen as the second most valuable public health intervention globally after providing clean water, there's still some way we need to go to encourage the uptake of these vaccines across the population, but particularly in at-risk groups. So we've got the flu here, we've got pneumococcal. These are the percentages that Patrick spoke to in his presentation, with lower than we would like uptake of these vaccinations, and definitely lower than the recommendation from the WHO. And we shouldn't forget childhood vaccinations as well, because these are important for at-risk groups, not just individually, but for creating herd immunity within the community to protect at-risk groups who don't respond maybe so well to vaccination. And for a number of years, we've seen a decline in the uptake. We've seen outbreaks of measles, and we lost, as the UK, our measles-free status. So there are some real issues here we have to work through, and it's, from a scientific perspective, it is actually really quite saddening, because vaccines are one of medicine's miracles. They are such an amazing output from many years of science to produce something as simple, in inverted commas, as a vaccine that can prevent ill health, can prevent death from many of these diseases. So there's a lot more we need to do in this space. Patrick, if you click on again, this is a graph that I took from the UK government's website at the end of last week, looking at the rate of vaccination. And again, a number of speakers have spoken to this already. And we've got over 80% of those who are eligible to be vaccinated, double vaccinated, which is an incredibly high amount. Now, this is the whole population that we're looking at here, of course, but clearly we've been able to get some things right during the pandemic, and some of those have already been highlighted. The caveat here is that there are still at-risk groups that haven't been vaccinated or fully vaccinated at that 80% level. So there's still a lot we need to do to engage with those communities. So I'll come on to that now. But I think the key take-home message here is that we're doing a good job of the pandemic, lots that we can take into routine, lots of learning we can take into routine vaccination, but we do need to keep that momentum going. So Patrick, if you click through to the next slide, as I said, excellent report from the ILC, and we support the recommendations from the report. From our perspective, there are three key areas I think that we would add significant weight on, and these are these three here. So very much around the communications. I think Christina or David alluded to this, which was that their vaccines have been kind of a victim of their own success, where they have worked incredibly well for routine vaccination programs, and we now rarely see those diseases in the community. So there is a complacency out there in the community around routine vaccination. So we need to champion vaccines. We need to talk about the value of vaccines. We need to get that message across in an open, trusted and engaging way. So that communication is still a challenge, I would say, that we need to be addressing. There's also the distrust, and this was picked up in the report, and Patrick talked about this earlier. Communication widely in one form is not enough for our society. Actually, for some communities, we need to be going various levels deeper than that, and we need to be directly engaging with these communities, understanding what their concerns are, and then doing our best to try and address those concerns, or at least discuss those concerns with them. And then, of course, the third area is around barriers to access, and we need to make sure that we have access to vaccines front and foremost in the community, so that there is almost no reason why somebody can't go and get a vaccine if they wish to. And again, a couple of speakers have talked to this already this afternoon. And if you click on again, Patrick, Pandemic, well, of course, has affected us all and changed a lot. And we've been able to, others, government bodies, other third sector organisations have been able to try out innovative ways to overcome some of these challenges. So in the final slide, I'm just going to talk to a few of the things that we've done at the British Society for Immunology and working in partnership with others, and that we know other organisations have done. And these are really the lessons learned from the pandemic that we need to continue for COVID-19, because job's not done there at all. And we need to take this into routine vaccination, which arguably is likely to see COVID-19 as part of our routine vaccination going forwards. So if we look at that first challenge around communication, we really do need to be empowering the individual to have all of the information they need to be able to make the decision that is right for them. We've been, as have others, been using social media a lot. So there's actually a good way of getting incredibly wide reach for fact-based information from trusted sources, independent organizations who have that credibility to get these messages across. We've run a couple of campaigns, Explore Vaccines and Celebrate Vaccines, which have been very successful. Others have as well. And I think this is something that's been really successful during the pandemic for vaccination. We and again, others have been providing information clearly available to the general public. And our guide to vaccinations and COVID-19 has landed incredibly well, which is great. Quite a tricky one to manage because it changes all the time. So it needs to be constantly updated. But it's there from, again, an independent evidence-based organization. So that resonates with many people out there in the general public. And we have a membership of over 4,000 people. There are other organizations, professional and charitable organizations that have membership, have networks, have those contacts. What we found is mobilizing your networks to go out, empower them, train them up to go out and have conversations in the community with their family and loved ones, then that can easily spread the word to those communities that we absolutely need to be reaching. So that's communications. The second area is looking at engaging with different communities and trying to overcome some of that distrust. So we've done that in a number of ways, again, always working with partners. We work with the Mayor of London, the Royal Society of Biology, to put some information out there on YouTube and on other social media platforms. We're having role models who aren't celebrities. Celebrities have a role, but actually real people who know what they're talking about and represent the communities that that are not necessarily coming forward as much as we would like them to be for a vaccine, talking about why they would have a vaccine. Those scientists from the Black, Asian, minority ethnic communities who are talking about the science, so more trusted by their own communities. But one particular program we're working on, it's been very exciting, is with the London Borough of Bexley, where we have been working with the local authority, with Public Health England, to train up the local community leaders, be they from faith communities or other communities. So training up those individuals to be more confident to talk about vaccines, engage with their communities, understand the concerns and respond to those concerns to really try and encourage their communities to get vaccinated. So that's been really successful, and hopefully is something we can take through to routine vaccination. We've also translated our materials into different languages, Yiddish, Eastern European languages, and put them out far and wide through various communities. And we mustn't forget healthcare professionals as well. They are, all of the surveys show, they are the most trusted source of information. So they are our greatest ambassadors out there in the community. And so we've run some webinar training, which seems to have landed incredibly well, which is giving that whole story behind the science, explaining about the science of vaccines, what's happening in the immune system, and those individuals feel more confident and empowered to go out and have conversations with their patients and in their community and answer questions and improve vaccine confidence to tackle that hesitancy that is out there. And then the final area, which has been talked to a fair amount already, which is the need to remove barriers to access. And we'd put that within the 3 Ps of people, place and policy. Christina, you talked about the huge expansion of the workforce. Absolutely. You know, we probably can't keep the workforce that size. Maybe we can, but we need to take the lessons there and need more paid staff and volunteers on the ground helping with these routine vaccination programs. The place absolutely need to be close in the community for people to be able to access without barriers. And then from a policy perspective, we need the funding. Of course, we always need the funding, don't we, from government to make that possible. And the political will to have this momentum carry on through to routine vaccination. And there is the long-awaited government strategy on vaccination that we hope will be coming out in the next few months or maybe year, and perhaps that will take into account, well, we will try and make sure it does take into account the lessons learned from the pandemic that we can again transfer to routine vaccination. So I think I'll leave it there. I guess I'm generally a half glass half full kind of guy, but I think from what we're hearing so far, I think we can do this, and we know what the challenges are, and we just need to keep that pressure on and enable that momentum from the pandemic to come through to routine vaccination. And again, I'd like to thank the IRC for a wonderful report and for organising the event this afternoon. Thank you.
Brilliant. Thank you so much, Doug. And I think the example that you highlighted of building trusted relationships with community workers is really important. I think it would be also really great to hear what the sort of challenges were in doing that. And I think we can learn from, not just the benefits, but just as equally from the challenges in doing this, so that when we do, when we try to implement these across the board, we can overcome these much faster and actually see progress much quicker on the ground. But thank you so much for that. Really interesting. Great. All right. So we're going on to our next speaker, Jenny Lippiett, Professionals and Practice Program Manager at Age UK. Jenny is a Professional Practice Program Manager in the Health Influencing Team at Age UK. Jenny has spent the last 5 years working in the health and care sector for VCSE organizations, including Diabetes UK and the Richmond Group of Charities, a coalition of 13 leading health and care organizations focused on the needs of people with long-term conditions. Jenny leads Age UK's work around their Winter Health campaign, where information on vaccinations and increased uptake forms a central part. Jenny, great to have you here. The floor is yours.
Hi there. Thanks very much, Aaron. That was, it's been really interesting listening to everyone else speak today, and thanks to ILC for inviting us along. It's really encouraging and welcome to see kind of voluntary and community organisations and charities kind of involved in this work, and seen as kind of having an important role to play. So thank you. I think this report had some really excellent recommendations and is, as a few people have reflected on today, I think really timely. Obviously, we're heading into winter, a really important time for many routine vaccinations, and it's just quite an interesting time in general to be in the world of vaccines at the minute. They're really front and center for kind of the population as a whole, or the world as a whole even, which for some of us who maybe talk about this every year is quite a new space to be in, but also a really interesting time to kind of build on some of the learnings and the insight that that has provided. I think, as I mentioned before, charities have and do have an important role to play in improving uptake. As highlighted by the report, that communication, the information element, I think, is of particular interest to us. We can have a really good understanding sometimes of what information people are seeking from us. People come to charities for information and advice frequently. And I mean, just as an example, we've had nearly something like 750,000 people have come to look at our COVID vaccine page, for example, since that kind of launched around December. So we are a trusted source of information for people. And I think sometimes what can be done quite well for charities, particularly kind of condition-specific charities, where people might have very specific questions about what that might mean for their condition, what that might mean for their medication, all those kind of things. And gathering that in one place can be sometimes even a challenge for some of us who know where to look. So I think there's a really important role there to kind of pull different information together, whether that's from healthcare professionals and clinicians who work in that space to where can I physically go and get my vaccine. Pulling all those kind of strands together can be really important. This has been said plenty of times today, but making sure that that information is accessible in multiple forms, offline, online, in different languages, from trusted sources, is equally as important, because we know that not everyone has access to all the information in the same places. So making sure that that's as widely available as possible. Something else which I think has become particularly noticeable in the COVID-19 vaccination program is the charity's role in actual providing that really practical support. So which can overcome some of the physical barriers to access that have been touched on today. So I know some of our local Age UK partners, physically took people from A to B to get their COVID-19 vaccination, where they weren't able to do that or had support to do that. So some of those just really quite basic physical, practical tools to get people where they need to be. This has also been touched on a lot today, but that the collaboration element on a really local level. I know my colleagues who work at Age UK London, for example, can work at borough level, but work with borough level organisations to really look at and address the specific needs of those areas and determine what exactly the barriers are there or what some of the hesitations are there, and working at that really local level and understanding the local need, whether that's a physical access barrier because there's not the greatest transport links in an area, to particular working with particular communities to make sure that they have the information that that they need there. And that also really nicely brings in that trust element that we've talked about a lot today as well. And sometimes charities, local community organisations can be a real trusted source of information, but also have those relationships that can mean that people are more likely to listen and more likely to feel safe to ask the questions that they want to ask. And Doug talked about kind of equipping community leaders to be able to answer some of those questions. And I think that's a really important route that has been kind of explored a bit further in the in the COVID-19 vaccine rollout, because those are the people that are really connected in with their communities there. The other kind of thing I wanted to just reflect on, I guess, which Christina talked about earlier, was around building on those new relationships and those new collaborations that have formed during the pandemic. In some ways, that emergency situation that occurred during the pandemic brought down a lot of barriers from kind of public sector organisations and charitable organisations kind of really working together to move things forward. And I think what Christina said about not going back to business as usual is something a really important point to remember. And I think I'd just finish on that not one size fits all approach that has proved, I think, to be very valuable in the COVID-19 vaccine rollout program. And yes, okay, this toolkit and this report has been focused on the role that charities can play, which is really welcome. But I think it's safe to say that there needs to be a whole system approach, and to ensure that information is widely accessible, that it's very transparent, and that it equips people to make the decision that's right for them, and by providing that really that important information to so people understand, so that people can really understand why is it important that I get this vaccine. I think is a really important element that needs to, I think that can also speak to some of the success of the COVID-19 vaccine program, is that people were quite aware of their vulnerability during COVID-19, which isn't always the case with routine vaccinations. I'm not sure that's also been the most positive of things throughout the pandemic, but I think that is a reason why uptake has been so high, is that people were really aware that they were more at risk, and this is why it is important you get a vaccine. And I think some of that is not always the case when it comes to other routine vaccinations. And I think I'll leave it there. But thank you very much for inviting me here today.
Thank you, Jenny, for that. I think it's quite reassuring that you echo what our other speakers say, because I think it shows that we're quite strong in our views in what needs to happen. I think it's just how do we move from us talking about it to actual action on the ground. But hopefully we can maybe discuss that more during the Q&A section of today. So moving on to our final speaker, our last but certainly not least speaker, Oren Lewis, OBE, co-founder of and chief executive at the African Caribbean Leukemia Trust. Oren Lewis is the co-founder alongside his wife, Beverly DeGale, OBE, and CEO of the 40+ times award-winning and world-renowned UK blood cancer charity, the African Caribbean Leukemia Trust. The ACLT was founded in June 1996 after Oren and Beverly received the devastating news that their 8-year-old son, Daniel DeGale, needed a life-saving bone marrow transplant to win his 3-year battle against leukemia. To date, ACLT has, on a cumulative basis, increased the bone marrow and stem cell register from 550 to over 150,000, and from which over 100 matching donors for sufferers have been found, helping to preserve and prolong the lives of many. Great to have you here today, Oren. Over to you.
Thank you very much, Oren. I really appreciate that. And it's been fascinating sitting here listening to the other speakers talk about this subject matter, which, because of COVID, has really shone a light on a situation, a problem in terms of vaccinations in general, and of course what COVID on top has done in terms of vaccination for the general population. But when you narrow it down to the hardest to reach groups, that's where I'm coming from in terms of an insight, an observation as to why there's a huge disparity in certain ethnic groups, either generally or as clinically vulnerable patients. You've heard my background, how I've started this sort of 25-year plus battle to save lives, and it stems from basically from a personal need, my son. But it's gone towards bone marrow stem cell awareness, blood and organ donation awareness for patients who need transplants, transfusions, to helping those patients who've received those transplants and transfusions, and the quality of care and support. Now, I'm going to look at it from a say particular at-risk group. Those are those classified as blood cancer patients, especially those who've received stem cell transplants, because their immune system is being totally eradicated because of having that life-saving transplant. But when you look at it in terms of vaccines, and this is something my son Daniel went through, you restart the whole process again in terms of having to have your vaccinations again, and there is a lack of clarity and lack of understanding, lack of knowledge in primary care about this on behalf of the patient. So the primary cares don't seem to understand that after the transplant, there is an urgency. There's a race against time to have these patients have to be revaccinated again, and there's a miscommunication with the actual stem cell recipients in terms of facilitating that, which is why the actual uptake, and this is right across the board of stem cell patients, there's only something like 25% who've been revaccinated after they've received a stem cell transplant. So you've got lack of knowledge is one factor that's causing a disparity in routine vaccine uptakes. If you then take it to patient hesitancy, that's another factor, because the patients they want to get on with their life, and for many it's a case of almost forgetting the fact that you've got to be revaccinated again, or it's low on their priority list. So you factor that in there as well. Throw in difficulty in terms of getting the actual vaccine, in terms of going to actually get a routine vaccine. I'm not even talking about COVID, just routine vaccine schedule for those patients is being difficult. What COVID-19 has done in terms of locking down access to primary care facilities is hampered that. And then the lack of follow-up between the transplant centers who have their own protocols and rules and logistics. It's not consistent in the stem cell transplant community centers in terms of making sure and understanding that these patients who they've helped find a donor actually need the top-up childhood vaccinations again. So you've got a whole sort of domino effect that affects these patients. If you then throw on top ethnicity factors, and I'm coming in from a Black and ethnic minority point of view, you then have a cultural and a religious factor that is hindering, as the stats have proved, are hindering uptake in terms of certain communities. The lowest you saw on the graph that Patrick showed, 32% of Black African Caribbeans. That is very, very low. Black Africans, not that much higher. If you then look at the COVID situation, what COVID's done is really magnified the problem in terms of the uptake of ethnic minorities. Generally, those over the age of 50 from the Black community, we're something like 71% of the uptake in comparison to, say, 87% of Asians, South Asians, and I think it's something like 93, 94% of those of the white community in terms of the uptake over the age of 50 for COVID-19 vaccinations. Now, one of the questions that needs to be asked and addressed as to why is there is a deep, deep inherent generational mistrust of the medical establishment across the board when it comes to vaccinations, which is why the uptake is so low. COVID has really shone a huge light on that and magnified it even more because of what the virus did disproportionately to ethnic minorities in terms of the fatalities. So there's in terms of why that's happening, and it's across all ages and it's across all socioeconomic statuses, because you're getting doctors, physicians were being affected by this, as well as Joe Public. And then if you throw in the clinically vulnerable communities, like I say, organ patients, sickle cell patients who need well-matched blood, to stem cell patients, especially those who've received a stem cell transplant. If you're Black, we're finding there's a deep mistrust, not sure whether they should take the jab or not, getting mixed messages, and looking for signs of reassurance, which they don't think they're getting en masse from mass media, the WhatsApp messages that have been out there in terms of the viral messages that have been perpetrated in certain communities in terms of saying stop, don't take the jab. So you've got a whole gamut of problems, especially for those who are from ethnic minorities who are clinically vulnerable. And so organizations, charities like us and other stakeholders need to step into that zone and give reassurance, give knowledge indirectly to those patients and the community at large, so to bring that level of trust. And we've done some things recently where we've done webinars. We've called one of our webinars "Black People, Let's Talk About COVID-19 Vaccines," and we had two, and our first one had over 900 people on that webinar, because they really they felt they could trust the ACLT to have the physicians and have a sensitive and culturally reasoned debate, discussion about this. And we had some people who were against it, Black people who were against the vaccine. So we just wanted to get both sides of the coin. So you've got all those factors in there. So trust is one thing, because in our community, there's things that have been done to our community historically, which have been really, really detrimental to our growth as a race of people back in Africa, in the diaspora. Things have been done, and they've been chronicled and well documented. We know it. I think what happened throughout the summer with George Floyd, Black Lives Matter, COVID, you had a perfect storm. And so it allowed us to actually show and express to the wider community, this is why we mistrust, because of what things have been done, are still being done to us. Communicate to us on a level which is more clearer, which is more culturally sensitive, and we will come to the table and we will take our jabs, but it needs to be through the pharmacies, as we heard earlier. My mom went on Monday. She's 90 years old, and she had her flu jab at her local pharmacy because it's there and she trusts it. So the right messages, the right messenger will make a lot of difference. And really just charitable organizations and the commission inside NHS England, Public Health England, NHSBT and so on, work with these organizations, these gatekeepers from the community, entrust them to literally retranslate the messages about vaccination, COVID as well. And I think you'll have a fighting chance to actually bring the trust level up, because we know this is what is needed. So I'm going to leave it on that note. But I think it's a case of knowing the audience. If you want people to come to the table to actually be part of this process, know the audience, know who to work with, and there is a good chance that people will come, because people really want to make a difference, but they are sensitive and they are tentative.
Brilliant. Thank you so much for that presentation. I think you really made it quite the clear case that we need to be understanding not just the COVID pandemic, but health in general as a historical process, not just something, taken in one point in time. And I think that's really important takeaway for us. Hopefully we can touch again on this point in the Q&A. So now we're going to be moving to the Q&A discussion. I'd like to remind audience members to use the @ILC UK handle and the Reducing the Risk hashtag on social media, and to post questions in the Q&A tab. Please do that as we're talking, and we'll try to get through as many as we can with the time remaining for today. Brilliant. Okay, so I think there are a few questions here, and I think there are a lot of themes that came out in today's session, but I think maybe we would like to take a bit of a step back from everything we've been talking about and consider a question that was put by Lynn Laidlaw, which is there a problem in the way that we frame this debate? And do people like being defined by their risk and their disease? And what are maybe additional factors we need to be thinking about, and who defines this debate and its terms? So I'll open this question up to anybody from the panel who'd like to respond.
I mean, I'm happy to kind of come in on that if that's all right, Aaron.
Of course.
I think from a research point of view, especially, I think from why we've kind of focused on these groups and why we use the terminology, we started by looking at the Green Book of Immunisation, which is obviously the big Public Health England publication on people with all the recommendations for people with underlying health conditions, those in clinical risk groups or at-risk groups as they refer to them. But I do think it's interesting, that point about actually putting that label on people and whether or not that does have an impact, especially on uptake or on how people perceive themselves. Certainly, although we only spoke to 8 people across those at-risk groups we focused on, certainly some of them did say that they felt they were more a part of a risk group than other people. And I think I remember speaking to someone with COPD. He really believed that actually it was important to kind of harness the communication around that and how you are at risk, and looking at flipping the data on low uptake and saying only 40% of people with X condition are vaccinated, are you? So there is that element to it. But I also think as well, it is important to kind of not to overemphasize it. And I kind of agree with Lynn's point as well there. I think sometimes that could dissuade people. They might feel like they are being, labeled, and particularly with certain marginalized groups, especially, this can be an issue, and it is a sensitive topic. So moving forward, you do need to work with those partners and those relevant people who can relay and communicate. And I think Christina made a lovely point earlier, translate those arguments. So using charities who have that tailored knowledge and that specialist advice to kind of really make people feel like they can engage with vaccination, not just because of them as a person with a condition, but because of the importance and significance that vaccination can have for their lives and their longevity. So yeah, I think that's a really interesting point.
Great, thank you for that. I think it's at times can be a difficult balancing act, particularly if we're trying to engender trust in communities and have messages that resonate with different communities without also singling them out in a negative way. Would anyone else from the panel like to share their thoughts?
Aaron.
Sorry, you go first, Doug. Go
Are
on.
you sure?
Yeah,
okay.
go first.
Great, thank you. So yeah, I mean, I agree a lot with Patrick said, and thank you, Lynn, for your question. We work with you, and it's great to see you on this webinar. But it's a really important point, and I think from our perspective, and it comes to that communication side of things again, where we almost need to flip the narrative away from making people feel scared about not getting a vaccine, but actually be excited about having the opportunity to have these disease-preventing vaccines in their arms and in their bodies. So actually, it's about, I think, giving the full scientific story, the process has gone through, why people should be excited about these, answering the questions and some of those concerns, but really trying to make vaccination the social norm and making it a positive interaction, and that people are crying out for them, rather than, as Lynn is suggesting, a passive scaremongering approach to it. I think that's definitely something that we could work on as a society.
Brilliant, thanks. David, did you want to chime in?
Thank you. Yeah, I'm just going to jump in quickly here. I think when one is looking at the impact of a vaccine preventable disease on a population, it's really important that epidemiologists and public health practitioners understand who is at greatest risk so that the vaccines can be targeted at them. And we've seen that with COVID, that those who were at the greatest risk were offered the vaccines first. And I think that's absolutely right and proper. But I do think Lynn has raised a really interesting point. So I'd like to come back to some of the stuff that I mentioned. I think in messaging, people need to see themselves in that message. So I do fully accept Lynn's point that all these sort of labels of sort of chronic kidney disease or chronic respiratory disease, that may not resonate with an individual, and they may not see themselves in that group. So I think it's important that the messaging is correct. And I also think this comes back to care providers as well. If someone in that group is eligible for a flu vaccine, that a personal invitation goes out, either a letter or a text message or a phone call or something like that. We know those sorts of approaches work, and I think that's one of the ways in which we can sort of break down some of these larger kind of at-risk type labels.
Can I just nip in there as well?
Of course.
I think, and I've actually just lost Lynn's question, but I think there was something really nice about the way she questioned it, which was, do people like being identified as such? And I think none of us like being identified in a reductionist way, and being reduced to a clinical risk or a disease doesn't fit well with any of us. Not to deny that, of course, we need to have risk profiles for, we need to segment the population into those who need the vaccination first for very good public health reasons. But I don't know that any of us feel like we want to identify with that. And I think that then leads to some problems. A particular bugbear of mine through COVID has been the term vulnerable. I think it's a really unhelpful term. I get why people use it, but I think vulnerable is something that very few of us ever wish to be. And I think identifying whole segments of the population as vulnerable is really difficult. And I think actually it's now feeding a counter narrative, which is, why should the majority wear a mask, stay in, have a vaccination to protect the vulnerable? Because the vulnerable are being othered into being a very small minority of the population that people can say that we don't need to protect. And I think it's a really unfortunate term. I understand why people use clinically extremely vulnerable, but I think it's a very unfortunate term. I also think it leaves a whole number of us on the edges of that category unsure about where we sit. So actually the clinically extremely vulnerable was a very, very tight, small group. There are a whole number of people, for example, living on various immunosuppressants who don't know where they fall along the continuum of risk. And I think it was always going to be unclear for people. It was always going to be an emerging picture. But I think there have been some unfortunate terminologies. I think it's also particularly difficult when we talk about groups that are unwilling to get vaccinated. So I think we have to watch our language really strongly here. And to echo Lynn's point, I don't think any of us like to be identified as a disease. Or
Can I just say, it's sort of like a welcome to our world, because this is the reality of labeling and how it's used or misused. Because you're right to say, in terms of the term vulnerable is now it's almost like a them and us sort of situation in relation to COVID. It's something that people of color, whether it be Black, Asian, whatever, mixed race, it's something that we've lived with, and we try to define ourselves and to be accepted in certain terminology. Now it's a case of this is now seeping into the wider community, and it is a case of, please learn the lessons from what's happened to people of color, how you use terminology, because it can really work against what we're all trying to achieve.
I couldn't agree more. And I also think it's where we have to be particularly careful when we talk about vaccine hesitancy. Actually, we have to be really careful of our language.
Great, thank you for your comments there. I think, really important points that you all raise, language being sort of the central way in which, if we are going to communicate with different groups, that, that needs to be first and foremost. There needs to be a lot of thinking that goes into this, and how do we communicate with different people. So really great to hear that from all of you. If no one else would like to chime in to respond to this question, I thought I might go to another question.
Maybe Aaron, I just want to add just very, very briefly on the back of that.
Of course, yes.
I was fortunate to have this discussion with Kemi Badenoch right in the middle of the pandemic. Obviously, she's the Inequalities Minister, and really understood, some of those issues that we've just talked about clearly. And one thing she recognised, and Orange said it as well, I think, that, some of these communities have their trusted community pharmacist right at the heart of their community. And what she wanted to do was sort of just see how many more of those community pharmacies in those areas where, people were perhaps not taking up the vaccine could be widened. And she recognised the access. So I think there's a job to be done about the messaging, but equally we've got to point people in the direction where there is the service. And I think many people just are not aware that that service exists. I think that's part of the challenge. It's not promoted well.
Brilliant.
I have to agree. I actually don't think people realize just how simplistic and easy it is to go to your pharmacy around on the corner on your high street for the service. I don't think it's being promoted in the mainstream media enough, or social media. It's there, but it's almost being ignored.
I've got to say, there are only at the moment about 1,500 to 2,000 out there of the 11,500. So we've got quite a way to go yet. But absolutely, there is probably one nearer than your mass vaccination centre. I think I described the Oxford thing, and I wasn't really sort of talking about queuing at the vaccination centre. I was thinking of queuing just to get to the actual area. The Oxford traffic can take you an hour to get across from one side to the other. But if you can go just a few hundred yards or even half a mile to your local community pharmacy, you're going to do that, aren't you, in preference?
Yeah.
Great. Thank you so much for that. So moving on to next question, which is from Neerja Jain. What is the one main route or intervention to increase vaccination among at-risk groups that you would advise to public health policymakers and practitioners? And I think maybe we can even expand this out a little bit more as thinking about what would be your key priority, or what would you like to see most happen to encourage vaccine uptake in at-risk groups as we move out of the pandemic, especially. Would anyone like to volunteer their thoughts?
I'm just going to come in here, and I think
Sure.
For me, if we are having to choose one, which is quite difficult, it would be around that information piece, which has multiple kind of factors contributing to it. But I think what the COVID-19 vaccine program really highlighted was the kind of convoluted and often different and mixed communication that really compounded people's hesitancy in some respects. And I think lots of us here today have spoken about the importance of making sure people have the right information in a way that's accessible to them, in a way that that answers their questions and allows them to make that informed decision is really important. I know it was only to choose one, but I think we also need to remember how well the COVID-19 vaccination program was resourced across the board. And yes, and that's, if you've got money behind it, we've been able to explore lots of different accessibility issues and engaging different communities in a way that we're not able to when it comes to other routine vaccinations.
Great, thank you. I think, sometimes it always comes down to funding, but I think the education piece is also really, really important. And I appreciate this is probably a difficult question to be asking when we've just had some really great presentations as to how varied we need to be in our response. But would anyone else like to share their thoughts?
Aaron, it's David. I'd like to chip in here.
Yes.
I think we need to be really careful about the debate around vaccine hesitancy. If you look at the uptake of COVID vaccine across the population of the UK, it's been an incredibly popular, for want of a better phrase, vaccine for the population to receive. We have some of the best uptake of flu vaccines in the over 65 population on the planet. The children's program, primary baby aims, regularly getting over 90% uptake. There is vaccine hesitancy out there, and it tends to be quite noisy, shall we say. They can be quite sort of prominent, if you like, in their messaging. But I don't think we're seeing huge amounts of evidence that's impacting on vaccination programs. I think, to come around to answering your question, I do think we need to make the vaccines accessible, and we need to ensure that any person who's eligible for the vaccine knows where they can get it. And I don't think we should lose sight of the value of a personal invitation. That letter, that phone call, that text message, to let the eligible person know that they can have this vaccine, and why they should receive it, what its benefits are. So I think for me, the biggest single thing we can do is to make sure that the vaccines are accessible, and that those who are eligible for them know how and where they can get. Thank you.
If I could just nip in at this point. So the joy of going third is I can, of course, grab the three that have already gone in terms of agreeing with all three of the points made so far. And I absolutely think that as we move beyond the first stage of COVID into kind of boosters, actually those personal invitations are going to get ever more important. I'm also going to follow Jenny in redefining one as two, and grab my two most important things. So the first thing for me is work with the experts, by which I mean the communities, work with communities of interest, demographic communities, ethnic communities, religious communities, work with the people who know best how to talk about vaccinations in those communities, and also in kind of at-risk communities. So work with the experts, including vaccination experts, health experts, our health professionals are really trusted. So use experts and have conversations with experts in communities. The second bit, and this is because I am a bit of a policy and data twonk, I would say build the data systems that allow you to performance manage the health system to know whether it is reaching the people it needs to reach. And that's really important to me. We currently have that data system for the COVID vaccination rollout, and it could be a real advantage to our routine vaccination rollout if we get the NHS to embed it. And I think this is a particular moment when we can. So for example, as I said, it's the first time when we actually know the uptake of a vaccination by ethnicity, and that's really important. It's really important to have that data locally so you can address, going back to working with experts, so you can address the inequalities in uptake. I will leave it at two.
Brilliant. Yes, I think, having the data there is really important. I know both Patrick and myself often get quite annoyed when we can't find quite basic data out there to be able to put forward, ideas and research, and it's quite frustrating. So yes.
And this goes back to Andrew's point earlier about how you get pharmacies into the mix, because of course one of the problems has been the flow of data from pharmacies back into our primary care records. And COVID might give us the moment to actually say to primary care, you have to now just accept this data system so that we can track patients if they've gone to their local pharmacy. So we know if they've been to a vaccination centre. Because one of the barriers, I was doing work 15 years ago about how you took health checks out into the communities that weren't taking up health checks. One of the barriers always is we can't get the data to flow back to primary care. Well, maybe now's the opportunity to say to primary care, this is the way we're going to do data from now on, because it allows us to open up those points of access. We have all been talking about how important accessibility is, how we need to remove those barriers for access. One of those barriers is you can't take services out to different communities because we can't get the data to flow from pharmacies, from pop-ups, from taking it to places of worship. If we sort that, and if we use COVID to sort that, we then can really sort the system, and we can sort the research on the back of the system.
Of course, I think, yes, having it supported by interoperable systems is really important here. So thank you for that. And anyone else, would you like to share your thoughts?
Aaron, if I may, Doug from the BSI.
Of course, yes.
And I agree with a lot that's been said in answer to this question. So I'll add an extra one on, but just to comment briefly on what the other panelists have just said. So absolutely agree, engaging with communities, community leaders, number one priority. I think that's it's labor intensive, but to be able to reach certain communities and groups, that is incredibly effective way to go about it. And I agree on the data point as well. On David, your point, and I don't know if you meant it this way, but I think I would push back slightly that I agree we are very fortunate that we've got higher rates of vaccination, but that of course has not been by accident. Totally agree that the accessibility needs to be addressed, but we should and I don't think you're suggesting this, but we should not take our foot off the gas when it comes to informing the general public and engaging with the general public in a mass communication way. That we've seen in the pandemic lots of questions, even though there's a lot of support for the vaccination program, there are still lots of questions out there. So we do need to continue to engage. And I think we've actually got an opportunity going forwards, because the scientific literacy out there at the moment is sky high, and the interest in the science and your own health is sky high. So if we can keep that momentum going forwards, then I think we could benefit from routine vaccinations. But the other area that that I think would be important, and Jenny, you mentioned this about the funding that's come through for the pandemic program. Of course, the economic case probably speaks for itself, though I know we will have ministers scrutinising the budgets over the next few years. But the economic case of a mass vaccination program is probably quite obvious when it comes to COVID, but I feel it's less obvious when it comes to routine vaccination. So, Christina, you mentioned about the data. Absolutely, if we can get the data, evaluate what is happening and identify those programs out there in the community and nationally that are working, and then layer on that the health economics, we can hopefully make a stronger case going forwards for the funding that we need for routine vaccination to be able to tackle the challenges that we've all identified this afternoon.
Brilliant, thank you for that. So I'm just a little bit conscious in time. We have about 5 minutes left for the Q&A. So I was just wondering whether Andrew or Oren would like to share their final thoughts to this either to this question or just more generally.
Yeah, I mean, I'm looking at the question from Naja on this one, and the one word that keeps jumping out at me is trust. That's got to be built. Everything else has to be layered on top of the trust of the communications, the accessibility, the messaging, but the trust of the at-risk groups, as we're calling them, as well as the general population, has to be built, and it's multi-layered. It's not the same for everyone. And so, as much as the message is about we need to get people vaccinated, and I totally agree with that in general, in terms of vaccinations, as well as the COVID jab. I think you've got to be able to understand and build that trust through the communications from top down, from government through the medical practitioners, through the influencers, who a lot of people in certain communities relate to on different platforms, in terms of the media, the arts, and so on, sport. As Marcus Rashford has highlighted, you can utilize certain key people to get a key message and a momentum going. And he's speaking on behalf of everyone. So there are models out there that we need to relate to and copy if needs be, to get the message across to these communities and these individuals, at-risk people. And it's all built on the trust. Everyone trusts Marcus Rashford because of what he's gone through and what he represents. We can do the same.
Great, thank you for your final thoughts. Andrew, would you like to?
Yeah, I think
final comments.
I just echo what Owen said, but you've got to have the trust, absolutely, 100%. But I think accessibility plays a massive issue here as well. And you know, we are in that world of convenience where, you know, the uptake of Amazon has demonstrated that people don't like to go outside their front door for quite a lot these days. And, you know, for certain things like vaccinations, you actually do have to go outside your front door. Although we have been taking flu jabs, of course, in our community to individuals who can't get out. So, you know, will that come for COVID at some point? I'm absolutely certain we will just treat the COVID revaccination program just like flu. It will become normalized in populations like flu. But I think, as Oren said, it's all about trust, but absolutely accessibility is also key. So those are my two sort of tops, really.
Great, thank you. And I think, you know, I definitely thinking about how has COVID changed our behaviors, and how do health systems, how does our health system and various community leaders and actors within that space have to change their the way that they communicate with us. That's also probably quite a piece of interesting future work that could help us kind of better support various different groups. So I think that's that kind of brings us to a close today. I just wanted to say, I thought this was a really great and interesting discussion that we had. It was really great to have such a strong panel of speakers. I hope we can see you again at more of our future events, also speaking at our future events. So just a thank you from all of us at ILC, and also to everyone who joined the webinar today. Just a few closing remarks from us. ILC's next event will be on Monday, the 4th of October, 2021, when we will be hosting a breakfast roundtable discussion alongside the Conservative Party Conference on the importance of including people of all ages in post-pandemic recovery. MP Damien Green will kick off a discussion on how to best maximize the longevity dividend as we emerge from the global pandemic and build back better. If you would like to know more about this event, please email us at events@ilcuk.org.uk. ILC have also just launched ticket sales for their 7th annual Future of Aging conference on the 2nd of December. This year's theme is on diversity and how we can make aging work for everybody. Find out more and register at futureofaging.org.uk. And of course, for news on ILC's latest webinars and to stay up to date with all ILC news, please visit ILC's website at ilcuk.org.uk. Join our mailing list as well, and you can follow us on Facebook and Twitter at ILC UK, and subscribe to our YouTube channel for all of our newest webinars and videos. I hope to welcome you at another one of our webinars in the or event in the near future. And thank you, everyone. Goodbye.
Thank you.